Okay. Joseph, whenever you're ready, feel free to present yourself and start.
Okay, thank you so much. I think I'm ready. Let me go ahead and share my presentation. Hi everyone, my name is Joseph Trinitas. I'm glad to see you all today, and I'm so grateful to be sharing my part of my dissertation. Actually, this is the second objective of my dissertation. The first one I'm doing right now, like I have submitted to the journal, is more like a scoping review of falls and falls interventions program that are available in the low middle income countries. So actually, my second objective is more like trying to validate the tool, and this tool has been used a couple of times in different areas. So I'll be focusing more on the steps and the procedures that I have been doing so far, and that's I'm looking forward to be able to go ahead and finish the validation process. So this work to me is very important because as we all aware of the context of the Tanzanian population and the global perspective of the aging population, like it's more increasing. And according to the WHO and other reports, it shows that globally 1 out of 4 people who are 65 years and older, they experience falls. And uh, uh, they end up going in the emergency room, and most of them they are dying. So this creates a lot of fear, and for people in this population to be trying to avoid some of the activity that they may subject them to falls. And this, to me, it creates another burden, which it calls fear of falling. And in the Tanzanian context, actually, we don't have this kind of there's no more research in this area of falls, and it's kind of an area that we should try to think about as the aging population keep increasing in low middle income countries as well as the other part of the world. Uh, so fear of falling is more like how these people they are more concerned to fall. So it's kind of uh, someone to be more precaution, like I have to avoid falls. So, and because there are so much risk into falls, these folks try to avoid activity that they may subject them to falls. And it's among of the common problems, especially as it can lead people to end up with fractures, disabilities. It also can reduce activities of life because in one reason people they may not like do exercise, they may not go out for a walk, they may not do anything because they may end up falling. So it's research shows that there is there's a connection between uh, people who are experiencing falls and the people who have had like a first episode of falls. And it's more prevalent for the people who have already experienced the falls, that it may make them like avoid a lot of activities because they may just to prevent the future falls. Okay. So why this is a problem? As I shared with you, 1 out of 4 they end up in the falling, and this is the global perspective, especially here in the United States of America. 38%, 38 million people that end up in the emergency room, and 38,000 deaths globally happens. So the cost of managing falls and fear of falling is kind of increasing. I remember for the past few years, it's around $50 billion, but now it's close to 150 estimate. And there is low evidence, especially in the Tanzanian context. We don't know how many people they are more concerned about falls and how many people have been experiencing falls. And in one way or another, based on my clinical background, working in the clinical setup, I do believe many people they may have this concern, but maybe we as clinicians we didn't open up to them like, hey, do you have any episode of falls? Or unless they come to the emergency room, they have maybe injuries that are falls related. And this I can try to relate from the work that we have been doing from injuries and TBI. People they may report falls, but I don't think if clinicians we are really uh, gathering a lot of information from these individuals. We don't know the prevalence rate. We don't know what are the risk factors in the Tanzanian community. They may be differ based on maybe the building, the area, the structure, or the environment. Uh, but we don't have that evidence yet. Also, we don't know how to measure, like how many instruments available that are context-based in this population. From the area that I've been doing research and doing review, there are a couple of instruments that they've been used. They have been validated into so many different countries. And all of these, there have been so much research on how they can be used to measure fear of falling. And the one that I'm going to share today with you, this is the tool that have been developed in the Europe and have been used in so many different countries across 36, 34 countries, and it has been translated into so many languages. And for me, I thought it could be also another advantage to use the tools to measure in the Tanzanian community. It's very important to understand the magnitude of these problems because want our we want to promote health aging. We want people to age to be like active in their own environment, in their own settings. But also we don't want people to end up in the hospital because of fractures and other disability that are falls related. The prevalence of fall or fear of falling, it's estimated from 20 to 85%, and it's so many diverse because of different contexts, as I said, in so many like the population and other risk factor that are present in that setup. But this is according to the literature that I have been doing, the big number, as you can say, like 85% of folks are experiencing fear of falling. So to me, is the biggest concern, and yeah, that we should focus into this area. Advanced age, people who are older than 65 years, women, they are more at risk, and people who are low self-esteem or anxiety, like fear of falling. The impact of fear of falling, it can reduce the quality of life. It can lead to decline in social isolation. Like people, they cannot go out for gathering, for events, because maybe they are afraid of working during the nights. We know the context in Tanzanian population, no street lights. Some people, they cannot go out. The roads are not good. We don't have the walkways, like so there are so many factors that they can contribute people to have the reduced physical activities or the quality of life. So in other literature review, like systematic review that I've been doing, it says more than 32 countries they've been using this instrument, and it has a good internal and external reliability. So the aim of this project for me, number one, is to perform the cultural translation and adaptation into Swahili, but also to establish its psychometric properties in these populations. As I said, this study, it can add a lot of value to our community, especially to be able to understand what are the factors, we can prevent falls, like the risk factors, but also it can be uh, uh, among of the screening tool, like maybe to assess or to ask people like how concerned are you about fear of falling. This study is guided by the theoretical framework, and this is the self-efficacy theory. This theory has been used to develop these tools, and I'll be using the same theory into my research to be able to relate and then measure all the associated factors on all the component of the theory. Uh, the theory says like the person who are having uh, higher self-efficacy, they are more likely not to fall. But those who have like increased low self-efficacy, they may end up like experiencing fear of falling. Uh, this is the cross-sectional study, and uh, it has two phases, as I said. Number one is translation. So what I did actually for the past few months, I've been translating the tools, and this tool I just translated based on the guideline that was provided by the Prevention of Falls group in the Europe. It has the author of the tools, they have their own guidelines that I have to follow, and I reach out to them, they send me their document and the procedures on how to go through the process. Uh, I was able to go through up to the level of uh, adapting the tools. I sent the tool to the people who are experts. They did the translation, the forward and back translation, but also I was able to administer the tool to few folks in the community in Tanzania, just to see how linguistically, how meaningful the tool is, if there is any difficulty or any challenges on the wording or the meaning or the interpretation of the tool. And I just received their feedback, and I've been working on finalizing the process. Uh, I'm intending to use this tool into the community in Moshi, and I'll be recruiting this participant from different areas. I'm thinking about where can I get this population, maybe in the church, using the church leaders, in the mosque, in the village, maybe working with the community health villagers and the health centers like primary clinician and other people. My target population participants should be above 60 years of old. And this is quite different from here in the US. They are more focusing on people who are 65 years of old. So in our setup, we know that many people, they are not aging that far. And sometimes 60, we just call as a retirement age. And I kind of use the same kind of point. Okay, so participants should be able to communicate like in Swahili, voluntary to participate, and consent. So all this should be among of the criteria. The sample size, I'll be using the G power, or I can use the rule of thumb, like trying to do the item analysis, maybe because this tool has 16 items, I could use maybe it to calculate the sample size. So I'm still trying to plan what exactly I should be doing. Uh, Another instrument that I'll be using together with these ones is the WHOOF, which measure the quality of life. It has 24 items. I'll be using geriatric depression scale, but also socio-demographic and clinical information. So these tools, they'll be helping me to understand all the validities and reliabilities, like the discriminant validity, the convergence validity, but also to be able to understand the criteria content validity. So all these tools, I have put them here because it's what other literature they have been doing into different contexts. And some of these tools has been validated in low middle income countries, not specifically Tanzania, but other they've been used in Nigeria, in Ghana, in Kenya. So to me, they could be they could give me like a good results based on the tool. As I said, the procedure that I've been doing so far, like translating and adapting the tools, and I was able to administer to some different group in Moshi. I'll be looking all the validities that they could affect maybe the interpretation of my results. So as I said, the content, validity, the construct, and reliability. So the internal test and the retest reliability, as well as inter-rater reliability. My analysis plan, I'll assess the discriminative validity, as I said, and the internal validity, but also I will use the independent t-test to be able to differentiate the fallers and non-fallers participant. But also, I will be using the correlation for convergence and divergent validity, but also the confirmatory factor analysis I'll be able to use. So all the measures that I'm intending to do are presented to this slide. So in a nutshell, I could say this area is under research in my country, and I do hope that the findings will help clinicians and will be more reliable and cultural appropriate to our community to help us to plan and prevent future falls or to have intervention that could help us to prevent falls among this population. So that's it from me, and I would welcome any comment, any question. Thank you.
Thank you, Joseph. So anyone has comments or questions?
I have one. Hi, Joseph. Congratulations for your great work. I have a question about the age cutoff point you mentioned of 60, right? And I was wondering if you or maybe your supervisors thought of applying as well a functionality scale such as CATS or Karnofsky, so that we could probably delimitate better that gray zone of those older people who are active and those maybe who are uh, younger but are more disabled.
Mhm, mhm. Great, thank you so much. I think that's a very nice point. I agree because some of the literature they've been also focusing on people maybe 50 and 55, especially assessing their functional level, like the physical functional level. So I think because right now I'm trying to go with what is recommended and what my population target has been so far, like 60 years and above. Uh, I don't think it's a bad idea to look about the functionality level of it, but it's something that I should try to think about because I do believe folks in Tanzania they may end up having this functional disability at the younger age and because of all the factors that we all understand. So I might include other tools though, because like I shared only three measurement tools, but I'm still thinking about being it broader so that it can help me also to have different groups of folks to assess, like maybe people who are younger than 60s and people who are more than 60s. Just trying to see the comparison and something like that. Great, thank you.
Thank you, Joseph. Happiness, do you have a question?
Yeah. Hello, everyone. So,
Hello.
yes, great presentation, Joseph. I think for me, this was like a new area of study, particularly when it comes to Tanzania. So I just wanted to understand, like in context, the false efficacy scale international, like how does it work in high-income countries? Like, let's say, is it a score scale that if a patient, let's say, scores 5, what does that mean? For instance, like we have like scales to measure, let's say, depression, let's say PHQ-9, like if we say it's less than 4, that means they have minimal symptoms of depression. That means maybe they may not require immediate intervention. So I'm asking in context of this study, I mean, the topic on fear of fall, like what does this scale, like in a nutshell, in the high income country, what does it say? Like when the score is this, is there an intervention to it? Yeah, just to try to understand the context in the high
Great.
income country. Yes.
Nice. Yeah, that's a very, very good question. Yeah, so these tools has been mostly used in high income countries. And from the systematic review that I've done, it has been used more than 35 countries, and it has been translated to more than 20 languages. And actually, it's an old instrument. It has been developed like in 2000, yeah, since 2000. And it has been used in Europe mostly because this original people who developed the tool, they're from the Europe. But uh, in terms of scoring, I didn't share it with you today, but there is a way to categorize or to interpret the scores based on the reading that you are getting from the tools. And as I said, it has like 16 items, and each items it has 1 up to 4 scale. And for instance, maybe one question can be how concerned about fear of falling. There is very concerned, somewhat concerned, not concerned. So all those items, once you add them together, you can get a certain category that you have to interpret. So maybe from 4 to 1, maybe 6 to 16, maybe 20 to 15. So they are all level of on how to assess. And actually this tool, which it doesn't really it cannot be used as a screening tool, but it can be used as among of the information that we can collect as clinicians in the emergency room or in the other settings, just to understand the magnitude of people who are more concerned about fear of falling. And in this context, we'll be promoting health behaviors or health activities like physical activities, exercise, because we may understand how people they are more concerned like to falls. And uh, it can help us to plan the interventions. Like, okay, maybe we have people who are aging, but they are still in their home settings, or maybe even at their home setting, maybe they're afraid to be left themselves. They're afraid to go to the shower or to go to the market because they say they're going to end up falling. So this kind of tool, it's more like promoting the self-efficacy, like building the confidence for these people and making sure that they are managing their physical function so well because we don't have them to be frail or to be weak or to be having poor quality of life. So the tool has so many items, as I said, but they can all tell us what is going on into this context, into this population. I think I answered your question very well, Mary. Sorry, is it Mary?
Yeah. Yeah. Thank you.
Yeah, so in the next presentation, perhaps if I'll be having enough chance, I'll share like what the instrument is all about, how many items has been, how we can assess the items and everything. So because now I'm still in the developmental phase of the project, I haven't gone so far like to be able to share so much information. And the aim of this presentation for me was just to get more feedback on how I can improve further my project and based on the context because we all know the context of Moshi and the population as well. So it's gonna be like a very good feedback from you for me to be able to move forward. So there's so much to be done into this work.
Yeah, congrats, Joseph. It's a great work. Does anyone have more comments or feedback to share?
Hi, this is Donaldson. Hi, Joseph. Thank
I
you for your presentation. I I'm really happy that you are working on this topic, and I was wondering, given what you shared in terms of fear for falling amongst the older patients you may recruit, do you have any intention to share some recommendations with them when maybe when you are recruiting them to also share some fall prevention strategies that they could potentially, consider to help them? You, even though I know your work is not an intervention at the moment, but I'm thinking, one potential way to benefit the participant you may recruit, or even the clinicians you may work with, at some point is kind of sharing any strategies you may learn doing your literature review or experience for them to consider.
Great, great, great. Yeah, so that's a very nice because that's my another phase of my project after this. And of course, there's potential intervention that could be done once we establish the magnitude of the problem. And we have intervention that have been worked so far so good in lower and the middle income countries. And although some of them they are kind of similar to the what have been done in the high income countries, but there are literature that they've been conduct, there are intervention that they have been done into countries like Egypt and other like Vietnam, India, and other countries that they have showed a very great uh, evidence that it could work also into other lower middle income countries in terms of preventing falls. So there are ways and there are programs that they could be used or they could be tailored into this population once we understand, and we could now move forward on how to prevent falls and the fear of falling. Because they are kind of going together, like falls and fear of falling. So like uh falls, once you fall, you can end up having fear of falling, like to prevent another fall. So they are both in two ways. So I love your question because that's my next step forward after this, and we would share the results as dissemination of the findings with folks, not necessarily those who participated into this study, but the entire community. Like we used to do like sharing and disseminating this information, maybe through community meetings, or maybe through outreach, or maybe through community programs that we could also tell our people, hey, there is this people are more concerned about falls. So how we could work together to make sure that we mitigate all those kind of potential barriers or potential factors that they may subject them to falls. So great, and I really appreciate for that question.
Thanks. Anyone else?
Joseph, great job.
Thank
I hope you can hear me because
Yeah, I can hear you okay.
great, great. Hi, Joseph. Great job. This is amazing topic. I was curious about how was the main challenge where in translate the FESA scale into the Swahili or updating into the culture context of Tanzania.
Okay, nice, nice. Thank you so much. Maybe, yeah, I'm sorry, I didn't go much into the translation phase. Actually, what I did, I most of these items, they are more related like to the functional level, like functional assessment level. Like you can ask people, are you able to take shower? Are you able to go out for a walk? So it's more like physical function, like activities of the daily living. And it hasn't been a biggest challenge into translation because I've used people who understand Swahili and like the bilingual, but also it doesn't have like difficult terms or phrase that people could not understand because all of them that I said they are more focusing on the activities of daily living. And the only thing that we encountered during translation, especially among of the people that I sent out the instrument, there was a little bit of discrepancy in terms of the word self-efficacy in Swahili. So people have to bring different interpretation. So which led me to sit down and discuss with them and agree which one we should pick based on the context and based on the like how people are used into those words. So we are trying not to, we didn't want to introduce like vocabulary to people whom we wanted to use their regular term that they've been used, but not uh, uh, to have different meaning with the original of the instrument. Another thing that was also another challenge among of the items, there's one question that says, like, are you able to reach, like, if something is on your top of your head? So other people have like a different interpretation into that. So we had to twist a little bit the Swahili wording, but to keep the English meaning, just for people to be able to understand. So there was not so many words that they were difficult for people to understand, and some of their recommendations they sent them to me, and I was able to incorporate into the Swahili version of the tool. So nice, yeah. Those were the kind of issue that occurred into the during the translation phase. So we end up engaging like uh, the official person, like who is more like Swahili translator, who is well trained to assist us in getting the new version of the Swahili that we were able to administer to the population. And so it gave us a very like similar to the original of the instrument. So the other thing maybe that it could happen once we start to validate the tool to the entire community, where we could be able now to say, hey, maybe there was a lot of issue, but up to now we haven't encountered any challenge so far, and we are ready to move forward to administer the tool to the entire community.
Great, thank you.
Great, thank you.
Anyone else?
Uh,
Okay, go ahead, Jerome.
mm,
Yeah, you can.
Okay, just a second because I wrote it down here.
Hi, hello, Joseph.
Hi, hi.
My name is João. Great presentation, great job. I
Thank
would
you.
like to ask you if your project will evaluate and map the presence of risk factors for falls like orthostatic hypotension, heart failure, vasovagal syndrome, sarcopenia in those elderly people that are answering those questions.
Yeah, so great, nice, and thank you so much. This project actually is I'm going to collect all those information so far, like so social demographic and the clinical information. I will also work on the analysis phase on how those variables they could impact. And I think your questions could be more useful in the next phase where I'll be planning interventions, I think, like trying uh, uh, to have like different groups of participants and measure their fear of falling, like people who are having commodities or whatever, maybe how could that impact their fear of falling. But also, I will use their clinical information just to see they could how they could discriminate other items from the fear of falling. So those that question could be answered well into the analysis phase once I'm done, but all those information I'm going to collect. But I'm not going to single out individual conditions, maybe hypertension or whatever. No, I'm just going to categorize like commodities, maybe, or multimorbidities, and how they could relate to the fear of falling. That's all. Just as not as a single disease.
Okay.
Yeah, thanks so much. Yeah, thanks, Joel.
Thanks, Joel. Uh, any more comments? Okay. Thanks, Joseph. It was a great presentation, a great work. Good luck with your work. We're happy to have you again presenting the instruments once you feel ready. If you have any questions or additional comments for Joseph, you can reach out to him by email or Teams, right?
Yes, right.
Cool. And we meet again next Tuesday. Thank you.
Great. Thank you so much. Thank you all for having me today. And I really appreciate all the comments and the feedback that you provided to me. Thank you all. See you next time.
Thanks. Bye.
Bye bye.